Secondary infertility, what it is, and inside an evaluation. Hi friends, I am Dr. Natalie Crawford. I'm a board certified OBGYN and fertility doctor. And today I want to talk to you about secondary infertility. Secondary infertility is when you've already been pregnant in the past, yet you are struggling to get pregnant with your next baby. This actually can be relatively common. About 30% of people will have secondary infertility, and it is hard because you don't fit into either category, meaning a lot of times you don't fit into the infertility community well because you have a child and there's sometimes resentment about not being grateful for what you have. Yet your family's not complete and you're feeling that lack of what you want. And so that means that you're not fertile either. You're right straddling these two worlds, and that makes it extra hard. It's also a mind game. Like when you've gotten pregnant in the past and now you're not able to get pregnant, it can be exceptionally hard to just wrap your brain around the fact that now you're infertile and you have to enter into this infertility world and this word that brings a lot of stigma associated with it. My job as a fertility doctor is to try to make this process as easy as possible. When we have secondary infertility, we usually just start with an evaluation. We want to get all the pieces of the puzzle so that we can then sit down, understand this data, and make a good decision for you. Today, I'm taking you along as I counsel a patient. So we do telemedicine, and I am seeing a patient with secondary infertility. So you're going to hear me counseling a patient real life on the basic evaluation for secondary infertility so I can walk you through what it is like. You have secondary infertility, meaning, you got pregnant before pretty easily, but now we're struggling to get pregnant with the second child. And this isn't actually uncommon. It's just frustrating. Our general take is to just do a complete evaluation at this stance because we don't know what's going on. And sometimes, was that first pregnancy just good luck, and there was this underlying issue the whole time. We just beat it. Or is it something new that has changed now? Or that could be kind of a new thing. So I'm going to walk you through the basic fertility evaluation for us, okay? So if we kind of start thinking through things that can cause, infertility, it definitely seems like you're ovulating. So having to have regular periods every month is important. Although I do know that if your periods are changing in length a little bit, then it might be a little bit different. So we want to check for some mild issues with ovulation. So the way I like to think about ovulation, and then I'm going to walk you through the couple tests we're going to do, is that if you imagine that there's a vault in your ovary, and inside this little vault is all your eggs. And every month, a group of eggs comes out of the vault. From that group, one egg is chosen to ovulate, and the rest of the eggs die, and then next month, another group comes out. Now, each egg grows inside a small fluid-filled follicle, and you can see these follicles on ultrasound. And the hormone that the brain sends out to get a follicle to grow is called FSH, so it's a well-named hormone. Now, what we want to think about is that little things can change in your brain, the secretion of FSH, and that can change your ovulatory pattern. So these can include thyroid abnormalities in a hormone called prolactin, and also having a lower egg count, fewer eggs inside the vault can sometimes change the interaction. So those are going to be the first kind of things that we are going to look at. So when you come in, I'm going to have you do an ultrasound. We're going to do an antral follicle count, or what that means is counting the follicles or the eggs outside the vault. From there, what we're going to do is then draw a blood test called AMH. AMH is anti-Mullerian hormone. It represents a very similar thing. So what's interesting about this vault picture is when the vault is more full, more eggs come out every month. So an average woman in her 20s will have about 20 eggs coming out every month. And as the vault gets less full and you're closer to menopause, fewer eggs come out of the vault every month, just one or two. So trying to understand where we are in this range helps us understand how, many eggs do we have? Are we getting to this lower end? Do we need to be more aggressive to try to achieve our goals if we're running out of eggs? Certainly, if you're running out of eggs, that doesn't cause infertility because if you're still ovulating, but sometimes it can make you ovulate a little bit harder to track, and we can improve some of those factors. So AMH is made from the cells that surround the eggs outside the vault. So if you have more eggs remaining, we'll see more on ultrasound and your AMH will be higher. And if you have fewer remaining, we will see fewer on ultrasound and your AMH will be lower. So these are markers of what we call ovarian reserve, or how many eggs you have. It doesn't give us a perfect timeline. Like I can't say, oh, you'll be in menopause at XXX years, but it's giving us an idea of where we're falling. What this does not tell us is anything about our age. So as we know, as we get older, we start to see changes in what we consider egg quality. And the way that I think about this is those eggs inside the vault are just sitting there over time, and just like the rest of our body, our proteins start to degrade as we get older. Yeah. And so at age 35, we usually like to think about, approximately half your eggs are going to be normal and about half of them are going to have random genetic abnormalities. And that's why at age 35 is like drilled in our head, right? We're like, oh, at age 35, we have an increased chance of miscarriage. We have an increased chance of chromosome abnormality, and we have a lower chance of pregnancy than we did when we were younger. But it does not by any means mean that most pregnancies are going to be genetically abnormal. The incidence of that happening is still overall low because most genetically normal eggs do not fertilize and do not implant. And that's why we see a lower pregnancy rate. We can't test that. So unfortunately, eggs are single cell. There's no test for egg quality, but we do want to do good lifestyle things to try to have the best egg quality we can. So we want to avoid toxins. So things like smoking cigarettes, marijuana, heavy alcohol use, heavy metals, BPA, plastic, some of those things. And we want to increase all the good antioxidants, vitamin supplements. So fruits, vegetables, prenatals, some CoQ10. And so I'm going to put that stuff in a handout for you called the lifestyle handout, where you're going to have instructions on, I should take some of these supplements to help my egg quality. I should avoid some of these things. I mean, none of that's perfect science, but it's helpful to us in just trying to understand the full picture. So we're also going to draw blood to check those ancillary factors, as I said, namely thyroid, prolactin, and we're going to check for diabetes and a vitamin D. Okay, so just some overall other endocrine things that maybe can cause ovulation to be off just a smidge, or could impact infertility a little bit on that aspect. So we're checking ovulatory factors, we're checking egg count, we're thinking about egg quality. From there, we also are going to want to check anatomy. So, giving birth is not a benign process, meaning your uterus grew, you gave birth, it has to heal up. And even though it's not common, we can see scar tissue form after a delivery. And so we want to make sure there's no scar inside the uterus or the fallopian tubes are not blocked. And so the way that we do this is with a test called an HSG, or a hysterosalpingogram. This is also known as an X-ray dye test. And how the test is done is a little bit of dye is inserted through the cervix into the uterus to show us the outline of the uterine cavity, and then if the fallopian tubes are open. So you just want to check, okay, everything's nice and open, great. Or, oh gosh, look, there's this blockage or scar or something else that would highlight that would be a problem for us. That test is it's quick. It's just kind of weird because it's like a pap smear meets an x-ray. So speculum goes in the vagina, a little catheter to the cervix, and then the dye goes in and you see the pictures right away. So it's fast, just kind of awkward. It is timed in your period. So that one is done between cycle days 6 to 11. So for us at the current moment, what we usually say is when you get a period next, that will be the trigger to be able to schedule and do that test. So that'll be on our list. So far we have ultrasound, blood work, x-ray test. Couple other things to kind of add on. So the next thing is going to be think through, you're not the only one in this party right now, so we want to check a semen analysis because we can see sperm abnormalities. This is probably one of the top things that can change dramatically from baby 1 to baby 2 when it comes to secondary infertility. So the reason why is just thinking through the fact that sperm completely changes over every 3 months. So unlike our eggs where we got a new group of, sperm all the time, our eggs are the same group we were born with. So, if we gain weight, have new behaviors, get older, sperm can be totally different than it was. So when we check a semen analysis, what we're going to want to check for is the volume, how much sperm is there, the concentration, the number of sperm per milliliter, the motility, how does the sperm move, and the morphology, the shape of the sperm. That's going to tell us about the functionality of that. Depending on what we find from the semen analysis, sometimes it's perfectly fine, sometimes there's mild abnormalities, sometimes there's severe abnormalities. Depending on which variable is abnormal, it might give us further insight. Oh, these lifestyle factors, or these vitamins, or this medication, or no, this is just what it is. So understanding the different parameters will be really helpful for us in deciding where to go from here. Another thing that can sometimes cause secondary infertility is something called endometriosis, which is markedly hard to diagnose. Occasionally, you can pick it up on ultrasound or that x-ray test, but most of the time you can't. Endometriosis is a silent disease sometimes. Sometimes it can cause pain. So the number one symptom is pain with your periods that gets progressively worse over time. Can also be associated with pain on intercourse, especially with like deep penetration, or GI changes when you're on your period. You have to do surgery to diagnose it. It gets worse over time. So the longer it's been there, these little implants of endometrial-like tissue get stimulated by every period. So sometimes, hey, we're years later than it was when we got pregnant before, and it becomes an issue now, even though it wasn't then. Sometimes, people have it and they have no symptoms. Sometimes people have symptoms. We do not usually undergo an investigation for endometriosis, since surgery is not a benign process. We just try to keep it in mind, and we think through, do we have risk for this, or do we have any of those symptoms? And if everything else is coming back normal, sometimes we bring this into the picture about how we approach treatment options. And the last thing we want to think about is something that doesn't cause infertility, but what we consider preconception testing, meaning we want to make sure that, we're going to have a healthy baby when it comes down to it. And so the things we want to check include, making sure that you're immune to rubella and varicella, and we know your blood type. But most importantly is something called preconception genetic carrier screening. This may not have been done when you were pregnant before, because the genetic screening is different now. We've got a lot more available to us, and we know more about it. The thought process here is that if you both carry a silent carrier condition, and if you both carried the same one, then that might be something that would make us choose IVF so that we could screen out a silent carrier condition instead of thinking about other treatment options. Yeah, so our basic approach is going to be to do all this testing, to kind of walk through the ultrasound, the blood work, the x-ray, the semen analysis, and then when it all comes back, we're going to sit down and follow up and go through what it all means, and we'll talk through our treatment options. It's so different when you have a child already, right? You don't have that same maybe desperation that, as you said initially, I'll do anything to have a baby for baby number one. For baby number two, it's a harder spot, right? Because you want to give your existing child a sibling, yet you also don't want to maybe dive into this infertility world and just give everything to the process. So there's definitely a balance that makes secondary infertility like a unique position. And it's also harder to find people who can relate to you, right? Because some of the camp is, well, you already have a baby, be thankful for that. And the other part of the camp is, but my family's not, maybe it's not complete. I always say you might feel different when you get the testing back. So how we feel now may feel one way. And then if we find out, oh gosh, my tubes are blocked, I'm not going to get pregnant without IVF. So we need to decide, do we want a sibling or are we good? And both are perfect choices. It's just we want you guys to feel confident in making the right decision for your family. All right, friends, I hope that was helpful and you learned a little bit, and you hopefully realized that having a fertility evaluation or a consultation is not scary. We are on your team. We just want to gather data and make decisions that are best for you. And you are in one right now, so you don't need to be afraid. Just schedule that appointment if it's something that you need to do. So we usually recommend evaluation if you're less than 35 and you've been trying for a year, if you're over 35 and you've been trying for 6 months, and if you're 40, probably even when you're ready to start trying. So those are some game points where you may want to consider talking to your OBGYN or a fertility doctor earlier. As always, I appreciate you guys so much. Thank you so much for subscribing to the channel. You can always follow along on Instagram at Natalie Crawford MD, or check out the As a Woman podcast. Thanks, friends.